Welcome to the ResearchWorks podcast, broadcasting live from the Oceania Academy of Cerebral Palsy and Other Childhood Onset Disabilities Conference 2026 in the beautiful city of Hobart, Australia. Join Dr. Dana Poole and the ResearchWorks team as we bring you an exclusive series of interviews with visionary keynote speakers and leading presenters, captured right here amid the groundbreaking discussions and innovations shaping the future of disability research and care.
Welcome back, everyone. We have another wonderful speaker today as part of our Oceania Conference 2026. Hope you've been enjoying everything so far. Marissa and I have been learning so very much and getting very into the conversations. They've all been a little bit longer than originally planned. How are you doing with that, Marissa?
I love it. I may be part of the reason to blame, but no, it's been fantastic.
It's been great just to be able to expand on presentations. I feel like the presentations, when you have a free paper presentation, you have about 7 minutes and it's a lot to pack in there, and you often have lots of questions, and sometimes you just want to know a little bit more. And so these conversations, I feel, are just so wonderful to expand. And our speaker that we have today is someone that I met actually through Sarah McIntyre when I arrived in Hobart, and introduced me to you, Timothy Scott. Welcome to the podcast.
Thanks, Dana. It's nice to be here.
So lovely to be here.
Nice to meet you, Marissa.
Thanks, Tim.
And I love that when Sarah introduced us, she told me about the work that you were doing, and it was so interesting and so intriguing. We thought we had to get you onto the pod. So thank you for agreeing to be on.
That's very generous. Thank you.
Wonderful, wonderful, wonderful. And the title of your presentation is In Their Habitat, 3D Visualisation Clinic for Remote Assessment in the Community of Our Intervention in Children with Cerebral Palsy. And there's so much about that is interesting and exciting. And we know that there's technology now that's becoming more available, but how do we use it? But before we get into that, how about we start with a bit of a background of what it is that you do now, and I guess the context of where you are to this place, really.
Oh, okay. Well,
give us some context, Timothy.
It's a bit of a history, but I started out as an engineer. Electrical engineer, and wanted to be a biomedical engineer. So after I graduated, I worked as a design engineer, and made the segue after 2 years, sort of solidifying my degree to learn about biomedical engineering. And I think for me, I'd been to a lot of lectures, so I wanted to get my hands on and do some practical stuff. So I ended up signing up for a PhD in neuroscience, and that allowed me to do a lot of nerve stimulation in the lab, and was very interesting at the time. A PhD is a substantial commitment, so it was a solid 3 years, but halfway through that I had the opportunity to be awarded a fellowship.
Wow.
To go to America to work on electrical stimulation for people with a tetraplegia or a high spinal cord injury.
Wow.
To restore hand function.
Yes.
For them using an implantable system.
Amazing.
Basically, this team had invented, stimulating the paralysed nerves of the upper limb.
Oh, that's so wonderful. I love
create
that.
grasp and release.
Yes.
So after I
can see where this is
finished
going.
That, I came back to Australia on my fellowship and started a lab at Royal North Shore. Worked with a terrific hand surgeon, Claudia Schwind, and we started doing upper limb work, and she was doing the surgery. And I was the engineer, and we did a lot of research and did academic thing and graduated some PhD students. And anyway, subsequent to that, I'm taking a long way around, aren't I?
It's okay. You've got a good story.
Subsequent to that, I decided that I probably wanted to learn a bit more and get a bit closer to the coalface for the people that I was interested in designing research for. Because as you get more successful in your research career, you get further away from the coalface. So
true.
I found that very frustrating.
Yeah.
That I was ending up writing proposals and marking other people's work or
the administration.
Papers and stuff.
Yeah.
And losing touch with why I was there. So I decided to go back to school and went to did medicine.
Wow.
And it was such a great course. I loved doing it, and it was a great opportunity. And it's taken me on a long journey. And as a medical student, I met a man called Adam Scheinberg, who's actually over there.
Oh, is he right there? He is indeed.
Anyway, I was sitting in his clinic, and I was so impressed with the way that he ran his clinic and the way the patients were interacting and the parents were involved.
There's a wonderful manner about him.
So that must have affected me, because I ended up signing up for advanced training in pediatrics and specifically rehabilitation medicine. So that's kind of brought me to my current role which is your question, as a rehabilitation pediatrician or a kids rehab doctor.
With an engineering and the biomechanical engineering background, neurostimulation. It's amazing.
What a wonderful history, but what a wonderful lens to come into this area as well. There is something so special about that breadth of experience that you have in another area and you apply it. It's just fantastic. And when I read the title of your abstract, I can see how they've all come together here. It's actually pretty wonderful. I think the only other person I've met who's both an engineer and I think he's a neurologist, is Terence Sanger in the USA. And I remember thinking, that is just big brain. And so there is just a big brain here as well. It's wonderful to see the commitment and really exciting. Thank you for sharing that story.
It's a lot of study.
It's a lot of study. That's the most impressive to actually knowingly let yourself endure that.
Well, the great thing is that you've worked so long and hard to get to a position, and you actually, when you get there, you think, I like this. It's really good.
Yes. Well, tell us a little bit more now about the context of this paper, why you wanted to look at this 3D visualization clinic. Where did this come from?
It's a great question. With our intervention, so I do a lot of Botox clinics for children with cerebral palsy, and we do other interventions like medication and therapy, and I send people to orthopedic surgeons and plastic surgeons for opinions. Our outcome assessments haven't been that great, I have to admit. I think people deserve better outcome assessments than how did it go. We might do Botox for someone who a 10-year-old girl wants to improve her swimming. She might have unilateral cerebral palsy and have difficulty raising her arm in a freestyle stroke due to spasticity. And so she might come to me and say, Dr. Tim, can you do some Botox to help me get my arm over for swimming in the freestyle? And I'll say, oh, yeah, okay, well, let's do that. And, we might do some injections, and then, 8 weeks or 5 weeks later, I might ask her and the family say, well, what do you think? How did it go? And this is my follow-up. And she'll say, oh, yeah, it seems to be okay. And, the swimming teacher thinks I'm doing all right. We can do better.
Yes. Yeah.
And so that's what this project's about, is improving our assessment of our interventions. And what it's going to do, if we can get a really good assessment of our interventions, whether it be therapy or Botox, surgery, or whatever it is,
wonderful,
then it'll guide our best practice. But it'll also, as an additional thing, provide a pathway for translation of innovation to the clinic. So that's the dream.
That's the dream. And it's we always have to have a vision that's greater, don't we? Like, for us to try to reach for it and see what's actually available. So what did you try to do for this? Tell us what this actually looks like, a virtual 3D visualization clinic.
So one of the overarching structures was that I wanted to do assessments based on the goals of the child. So what that meant is doing it in the community. So we were trying to work out a way that we could do that. And there were two possibilities came up. One was to do it using a wearable sensor.
Yes.
Where we could use a system like Xsense or something like that to upload and send models through the internet back to the lab. and recreate that in a 3D avatar, as well as produce kinematic or biomechanical data as evidence as well. And so we could do that, have the evidence and produce the avatar so that all the clinicians could be in a 3D virtual environment looking at the avatar, say, of our girl before swimming across the room and in a 360 degrees, so you could walk around and watch this person swim across the room in your 3D visualization clinic. But you'd also have the data, so it gives you a basis of evidence if you need to publish and produce quantitative data.
So it would give you the shoulder flexion extension.
Exactly.
Wow.
That's the plan. We always had the avatar in mind, but the other approach was to use a video analysis using a domestic smartphone. So we're using pose analysis. There's a lot of talk about pose analysis, a lot of development going on.
Yes.
So we're doing some of that, and it's going to improve as we're talking, I'm sure.
Oh, absolutely. It does feel like it's a whole area that's just booming, really, and the models are becoming more and more accurate and inclusive of more different body types now. Yep. Oh, very, very good. Yeah. Okay, so what did you actually do for this? How did you...
Between the two choices?
Yeah.
Well, we have a co-design group and people with lived experience. It's actually run by people with lived experience.
Oh, wonderful.
And which was they're just standard. Fantastic. And I sat in on it as this kind of like plonker in the background. And it was really great. I just felt so inspired by it. And they kind of felt, wearable sensors, how reliable it's going to be in different environments and the community. And when you put the garment on, is the positioning going to be right? It's more something you have to wear. So is it going to, make me look different to what I want to look like? And, a few questions around that. So they were cheering for the domestic smartphone. So that's the way we went, doing the video analysis.
Yeah, so on a smartphone. And that's the most wonderful thing, isn't it? Smartphones are pretty incredible.
I mean, it's been exactly already in the conference we've heard about it being used for parents to, upload videos of their babies to
early detection.
For their exactly, assessments.
Yeah.
Telehealth obviously is a big thing.
Definitely.
So how do you envisage using a smartphone?
Well, ultimately, as I understand it, for these algorithms, the pose analysis algorithms to work really well, you need a bit more data. So I think you'd be videoing the young person, from different angles at different times.
Sure.
And so you'd get a good picture and cumulative picture of what their function's like and what the angles are doing and what when the joints are in different positions.
Okay.
I think you could do it, depending on their goals. So if their goal is to be a better footy player, you might be able to video them at their playing footy or, in the swimming pool or doing whatever they want, jumping on the trampoline. I don't know.
Yeah.
Lots of
things.
things.
Really functional, really participation-based. I suppose it's just less, so botulinum toxin, for example, or any of the medications you might prescribe, whether it's Artane, dystonia, whatever it might be, there's a body structure and function change that you're hoping to influence there, right? Yeah. But we always want to take it the next step to know whether it's actually impacting their life. And that is life outside of a clinic. It is life out there that you don't always get the opportunity to see. And you can't possibly, because you have so many patients, you can't always be outside, even though it's probably where you want to be. But it's not the most efficient way to do things either. So this just brings everything into a space where we can make an objective evaluation, which muscles, how often.
Yeah.
Great vision.
Potentially do it in real time, or if that's not possible, they could do it offline. Here's my avatar for my swimming, at home, or I was at footy training the other night, and here's the data. Yeah. And we could recreate from that.
Wow.
So
So where are you up to with it right now?
Well, that's a great question because the progress is a little bit slow. From my point of view, I'd love
your
it to go faster. The important thing was because we were giving so many freedoms, getting out of the clinic and people doing things of their own choice. But ironically, we had to go back to the most constrained, formalized, studio-based system to be able to validate and make sure that what we were measuring was actually the right
correct.
thing.
Yes.
So we went back and we teamed up with the 3D Gate Lab,
Brilliant.
and we used our techniques and compared it with the outputs of they use a Vicon system at Children's Hospital, Sydney Children's Hospital Network. So that's what my presentation is talking about, the validation side of things.
And was it good?
It was promising.
Yeah.
So it wasn't perfect. I talked to some of my orthopedic colleagues, and for making decisions, orthopedic decisions, surgeries, and things like that, they felt that they needed 99% correlation.
Wow.
Okay, which we didn't get for most of, but for making an assessment of an outcome, they felt 90% was sufficient.
Right.
So for most of our measures across joints in the abstract, we are above 90%, well above it in many cases, but not all of them. So there's a few outliers which I think as the algorithm improves, it will become reality. And also as we get more views, because with the gait analysis, we pretty much only have 2 views, sagittal and coronal, if I'm allowed to use those terms, from the front and from the side.
Yes.
So, the data is limited. So I think as the algorithms improve and we get more video data, it's going to get better.
Greater volume. And I can see the ones that were sort of on the lower side, which is, it's not surprising that those angles that come up, where are they? 0.75 for pelvic tilt. Pelvic tilt, they're hard measures because it's a 3D plane. It's a really hard one, but that's still pretty good measures. And 0.84 on the right side. How exciting to think that that's where it's going to go. I mean, Marissa is at Healthy Strides, we have our own 3D Gate Lab, and we do a lot of development when it comes to using pose estimation as well, because there's a lot of open source now, and you can run these off your mobile and off a laptop. We would still use 3D Gate for really full evaluations, right? If you really have
gives you that very thorough gold standard.
Yes, because you combine it with probably a full biomechanical functional test. Like that's your full workup. But for every day, we need to do better than just visual analysis.
Absolutely. Yeah. Because you can be specific, because if parents are unsure if it's made a difference, like you said, do you want to be going down the road of these medications and interventions, and especially when some have side effects.
Well, it's not nothing that people go through. It's quite. It's a lot of personal resources and time and for the families as well as for the team, and also, as you said, there's side effects and morbidities that can come from surgeries and things like that. So it's not without risk. We need to know that we're going to get. It's got to be best practice, and that's the way to improve things is to have good data.
And I feel like this could flow on so well to other clinicians and other healthcare professionals that work with these children. Like if you're doing this after having, botulinum toxin injections and do you know what, because of this range is looking like this, let's change their orthotic. Like they now need to move to more of a fixed AFO to allow them to maintain their ongoing changes from the Botox injection. So I think it just allows us to be more precise is what we're saying, doesn't it? And we can say with confidence, this is where we should go. It's best practice.
And I also think just from a smartphone perspective, right? Android is very available in so many parts of the world. I just think Southeast Asia, we do a lot of work there. Everyone's got a phone. Everyone's got Wi-Fi access there. They've got great internet access in a lot of the places through Asia. But then what they would often not have is maybe access to a health professional that can interpret what they're seeing.
Yeah.
So it just makes the world that little bit smaller and more accessible. So where to now for you? Well, now that you've shown good promise.
Yeah, good promise. So obviously I've got a big team of people, and we collaborate across multiple institutions, and I guess improving the algorithm, but the second phase of my proof of concept study is to look. Actually, interesting you mentioned the AFOs because I wanted to do a clinical project to solve a clinical problem. So I'm interested in some of the nuances between hinged and solid AFOs,
Yes.
and what goes on inside the the skin to AFO interface. So I wanted to image that as part of our avatar. So we're doing some new. This is novel work.
It is.
Because the orthotists are quite excited, going, well, this will change our practice.
Bet it will,
Amazing.
yeah.
What's going on inside there? Because sometimes for no good reason, people prefer
Yeah.
the hinged versus solid and vice versa.
Right.
Like,
Yeah.
what's that all about?
Yeah.
So what I'd like to do is to be imaging in dynamically as per someone, say, walks across the room or moves, what's going on with the forces. We can do it in colour, but we can do it in terms of data as well, so the numbers as well as the pictures. So that's kind of the next stage. I mean, ultimately, beyond this phase, which is, kindly being funded by Sydney Children's Hospital Foundation, the Cerebral Palsy Alliance, Hospitals United for Sick Kids, and AMP Foundation.
Wow. A lot of interest.
It's
Yeah.
a bit of a plug there.
Yeah.
It's the broadening of the project and the translation.
How it scales from there.
Yeah, translation to other centres and things like that. We're doing, the first step is gait, but upper limb function.
Of course.
Things remote measurement, such as pressure, skin pressure. For people who might be have pressure issues in their wheelchair or on a bed, is really important. So that's kind of where I see it heading. So technology transfer is where I'd like it to go. Ultimately,
Exciting.
and the thing about being able to do this assessments is that if we can do it remotely, it removes part of the burden of care of families having to travel to major centres for those country people.
It is not easy, is it? Like the whole process of it, surely it can be better. And I love that you thought that. And I think we should always be challenging ourselves to think, surely it can be better. What can be better? Because just because it's always been done doesn't mean it's the best thing.
Absolutely.
And you speak both languages. I love that. You speak the medical language and the engineering language.
It's
and
very
what a skill to
exciting. I can see
have.
how excited you are when you talk about it, which is wonderful.
Please keep in touch with us. It'll be something that we'd love to just keep updated on, because this has significant impact for many organisations and clinics and what the possibilities might be, because we can all do this better and we all know it. That's
Thanks,
fantastic.
Dana.
Thank you.
Yeah, thanks, Tim.
Thanks,
very,
Marissa.
very much. Hope you all enjoyed that. Hope that inspired you. It certainly inspired us. And, that's the power of coming to these conferences, is just hearing about things that are up and coming. And some of this work isn't published yet, but hopefully will be soon, so it can spread even more. But what a great way to get information. So thank you for being on the pod, and we'll talk to you all again really soon. Bye.
Bye.